Good afternoon, everyone. What I'd like to talk about today is maybe not only the way to a smoke-free world, because this is the way that we are all in, and we are active and we are trusting that we're heading the right direction, although some of us had a better one than the others. Sorry, this is my conflict of interests. Still, I'll start with the public health and the economics of chronic diseases. It's very often that the decision makers or the policy makers, especially for the healthcare, forget that there is some money behind what we are doing in the hospitals, and it's not only money that has to be paid for the hospitals, for the drugs, in salaries to doctors, nurses, and so on and so forth. But this is money that's being lost to the society, and this is money that's being lost to the industry, which we call all indirect costs. And these indirect costs, in many cases, especially in the respiratory diseases, are at least the same that the direct costs, so the money that we spend directly to treat or cure the diseases. Let's have a look at the most general statistics. Usually when we're talking about the longevity or the healthy nation or unhealthy nation, we try to compare the expected lifetimes or expected lifetime at birth. And we believe that those wealthier countries do have longer expected lifetimes. Well, that's true. As you see, this is the data from 2022, and you see that more or less there is kind of a proportion between the richness, so the income, the x-axis, and the life expectancy, which is in the y, so the vertical axis. If we go 200 years behind, we see that there was also kind of a correlation between these two numbers, although the income was much lower and the expected lifetime was also much lower. What differs these two times is that, the curves are of the middle. So middle curve, I'm sorry, I don't have do you have a mic I could sometimes, or a pointer, or that I could, show something in the screen? Well, anyway, you see that there is a difference. So there's a difference in angle. The ideal proportion would be if it was the 45-degree to the axis, but none of them. Oh, okay, excellent, thank you. But none of them reaches this point. Just let's have a look. The ideal is the green line. For some reason, neither now nor 200 years ago, we are meeting the ideal criterion. Why? Because the longevity was not only depending on the wealthiness, the amount of money we have and the amount of money we can potentially spend on our health, but it was wars, it was plagues, and now we have wars, plagues, and NCDs, so non-communicable diseases, the chronic diseases that are more and more often being called the lifestyle diseases right now, because they're depending on the lifestyle risk factors, including the behavioral risk factors, where we have alcohol drinking and cigarette smoking. So that's how we come to the subject of today's conference. Of course, the NCDs, they start and develop in adult's life because, the risk factors you have to be exposed to, they need time to act on your organism, and the organism needs time to develop some disease. So it's pretty obvious that the NCDs are diseases of those 45 plus, generally speaking. It hits us, so we need to spend more and more because we live longer and longer, and the percentage of those 45 plus in the population is increasing. So when they have the NCDs, the treatment of them is getting more and more expensive, so we need to spend. Plus we had the pandemics, which rose the costs of healthcare around the world on plus 15% on average, depending the country, well, the differences were. But still, as you see, no matter in which country group, considering the income we're in, the expenditure rose pretty high in the recent years, and in high-income countries, it's reaching 10% GDP. So 10%, every 10th dollar we produce, we make, is being spent on our health, which is, I think that we came to a wall. We can't cross it because we can't spend more. Because 100% of GDP is always 100%. We need for education, we need for infrastructure, we need for everything, and it has to add up to 100%. So we take another extra percent for health. We need to take it from someone. It's not that this 1% will be simply added. No. It has to be taken from someone, and especially that the health priority rose very sharply in the past years. The lower income countries cannot already afford further rise. One of my favorite parts of the Worldometer page is looking at the spending. Well, the spending here below, it says that today, we spent 11 billion for health. Today, well, sorry, not today. I accessed the page on the 29th of August, so it was a couple of years ago, a couple of days ago, and at that day we spent $11 billion on this day. And the same day on education we spent 7 billion, and on military we spent 3 billion. So altogether, these two expenses, military plus education, was at the level of healthcare spending. And still the healthcare spending is the most underfinanced care in the world. So we see the reason why we need to find other ways, because, well, we are not willing to spend more because the GDP, well, has its limits. We're spending more than to any other of the public services already, so we need to do something with that, because otherwise, well, looks bad. And still, even though we're spending more and more, the years of healthy life lost, because it's not only that we want to live longer, no, we want to live longer in full health. So even more precise than the year lives lost are the years of health life lost. Well, at least it's for those who are dealing with healthcare and public health, they know very, very well this one. And when you see what we are good at, we are lowering the risk at child growth failure. We're good at lowering occupational risk because we focus on that, and they are relatively well taken care of in wealthy countries. I'm not saying that they're well taken care of all around the world, but no, they're well taken care of in wealthy countries. So we're not saying that they are anymore real leading public health problems. But still, when we look at the high body mass or cigarette smoking, yes, these two are still the major problems of the public health care. Well, when you look at the deaths in Poland, I show you two groups. One, people in a year in 40, 45 years of age, and they dying of because of cirrhosis, ischemic heart disease, other alcohol use disorders. So you see that 40 years old guys in Poland die because of excessive drinking. Taking together. Then let's say, well, he survives. The guy survives, even though he was drinking. Then he turns 50, then he turns 55, and he dies because of ischemic heart disease, trachea, bronchial, or lung cancer. So typically, the two leading causes are cigarette causes. So when he survived the alcohol, well, he doesn't survive. A decade later, he doesn't survive smoking. So these are really the two major risks when you look at the death profile in the Polish society. Well, We're talking that we do not have money, especially we do not have money to add to what we already spending. But one of the ways we need to look at the healthcare is we need to look at the long-time financial. Well, earlier this year, namely in June, I was asked by our parliament, there is an office of analysis at the Polish parliament, to prepare an analysis actually addressing 7 questions that came from the government and from the parliamentary members on the current situation related to nicotine dependence in Poland, addressing socio-economic aspects of this. So let me show a couple of only pieces of what was in this document. Well, first I looked at the NCD mortality rate, Poland 2021. The data I obtained, well, I think these are the best data right now in the world. So they are from GBD, the Global Burden of Diseases, Seattle University of Washington. But using this data, I showed that in Poland we have 5 leading causes of death, which are ischemic heart disease, stroke, lung or bronchial cancer, COPD, and the diabetes. It's not shown in this table because it didn't concern smokers that much, and this analysis was mainly showing the smokers. So anyway, you see that for lung bronchial cancer, we have extra deaths, so unnecessary deaths yearly of over 1,000 people per 100,000 inhabitants. It's 1% people dying of the total society, dying unpurposely for cancer. That's 95% due to cigarette smoking. And also you go the ischemic heart disease or stroke, so brain stroke. Of course, I mean you have the same result. Well, as I told you, not only we tend to, or we would like to live longer, but we also want to live a better quality of life. So all the life lost are the one that we need as a system or a public health workers or researchers, we need to address and to improve them so that really we do not lose the life years uselessly. But when I looked at the years lost, we have 200,000 years of life lost yearly in Poland due to ischemic heart disease, 240,000 years lost due to bronchial and pulmonary cancer. So it is already 500,000 year life lost in the Polish society. That's a huge amount. Well, let's move a little further. Now that when we go to estimates what percentage of the health damage in every of these leading causes of death, so once again, ischemic heart disease, stroke, lung bronchial cancer, so what percentage can be attributed, so it's attributable to cigarette smoking. So again, going to the global burden of disease statistics and estimates, we know that around 30 to 40% in cardiovascular diseases is attributable to smoking, and around 80% in cancer, around over 60, so 2/3, 66% would be 2/3, we have 63% of COPD is attributable to cigarette smoking. When we take this percentage, and the losses that I showed, the life years lost and money lost, and we see that approximately 50% of the costs can be linked to cigarette smoking, so are attributable to cigarette smoking. So we would be able to save these costs, so lower the cost of the total healthcare, in case the society, well, no one in the society would have smoked. Well, of course, as it has been discussed, I'm also not thinking that it's possible that we all start smoking and we all stop smoking and stop drinking at all. But you know, lowering the bad habits in society will also bring saving at the percentage adequate to the percentage of those who decide. So once again, we have the costs which are out costs, so the cost of people getting sick because of smoking cigarettes, and the in costs, which are the income to the country budget from the market. There's excise tax, there's value-added tax, these are other taxes, well, workplaces, at the factories, and so on and so forth. So these are the in costs and out costs. So let's look how it's in Poland. Well, health expenditure on the 4 diseases in question were around 7 billion Polish zlotys. That's around the 2 billion euro in 2018. We have no newer data because the Polish National Health Fund hasn't published from the beginning of the pandemics any data on the division of their costs. So we know how much they spend, but we do not know how much they spend on this or another disease. We know only the global. So the only thing I can show if I need to divide it into some disease groups, so the only thing is 2018. And at the same time, we grabbed, so the government got from the market around 23.5 billion zlotys. So, well, of course, they got 15 or 16 billion more than they spent. Otherwise, they got triple that much as they spent, which makes me think, well, which of the Minister of Finances would ban cigarette smoking? Well, if he does, well, his next year budget collapses. Well, at least what it looks from these numbers. I think that the analysis that went also to the Minister of Finances, so he perfectly knew it, but I'm afraid he didn't expect that anyone except of himself knows that. But what we did later in this analysis, we assumed we have around 2 million people smoking in Poland. The society is 38 million, 2 million are smokers. I think that there are many more smokers than 2 million, but this is the official data of the National Drug Agency. So let's say we have only 2 million of smokers, and we have the direct and indirect cost estimate for, as I told you already, the 2018. Assuming that out of this 2 million smokers, half of them, because in most researches, we see that around 45 to 60% smokers declare they would like to try to quit at some time point. Not today, maybe tomorrow, maybe I already tried a week ago, but still, they're talking about quitting or reducing. So let's say we assumed, this is a living structure, so all the yellow numbers can be changed, and then you have different results. But we assumed the situation that 50% of the smokers are willing to quit, and half of them go to the nicotine replacement therapy, half of them go to e-cigarettes or heated tobacco products. And we assumed also the efficacy, short-term efficacy, because we know that long-term, so a year or 2-year efficacy is around, let's say, 20%, 15%. But even at a short-term assumed high efficacy, we can avoid about 700,000 smoking cases a year, which means 30% of those who smoke can gradually stop smoking. Even if we assume that we have 50 to 80,000 new smokers every year, if we were able to have this average smoke quitters, in 15 years, only 3% of the society in Poland still, this would be smokers. if we go this way. So if we substantially support the alternatives, well, and then they continue replacement therapy and in this or that way. This is not only the case of Poland. When we look at the entire world, we see that almost 2% of GDP, 1.8% of GDP, is being lost around the world because of smoking. The Americans are more accurate, more adequate, so they calculated that, well, the costs of smoking is around $600 billion in the US. 240 is healthcare, so direct costs, healthcare spending. 180 around is the productivity loss from, well, because of the illnesses. The sick people don't work, or they have, we know the presenteeism and absenteeism, both are related to the diseases. Then another 180 million will be due to the productivity loss just because of premature death. Well, the diseases I showed you, the lung cancer, they are deadly diseases. They kill also young people. Young, so productive people, 45, 50, 55. So they also are sick from this disease. They also die of because of cancer. And finally, we have 7 billion losses in those who are only second-hand smokers. Let me stress one thing. Smoking cigarettes is the only habit when you smoke and the others suffer. Because when you drink, well, directly, maybe they can suffer when you drink and drive and because an accident. They suffer when you hit them because, well, you're drunken. But it's not that you smoke, you just exhale, and they inhale and they get sick. This is the only case of any risk factors possible. And I think that this was well understood by several countries. Let me take here the New Zealand as one of the instances. Of course, I could take the Sweden, I could take Great Britain, I could take United States, I could take Czechia. But well, let's stay with New Zealand. They've been preparing for the great day that's gonna come the next year, the 1st of January. They've been preparing for 12 years. And I admire what they did because they did both. The lower pink line shows the policy of educational campaign. And the upper blue line shows the policy of banning and the policy of fiscal mechanisms for public health. They had a roadmap for increasing taxes on cigarettes, and they did it 10 times in 12 years. And every smoker knew that this is inevitable, that the next year this cigarette will be still 10% more expensive than this year. So it was kind of stress stimulus helping to quit those who intended to quit. And I would like to focus shortly on the lower line, the pink line, because education is the only way to have a smokeless society. Education, but started at grammar schools, at the kindergarten, and repeated every single moment and every single year. Because educating those who already smoke, well, it's also a good thing to do, but it will never make them ever non-smokers. Well, non-smoker ever is the most valuable person in terms of non-smoking because he or she never smoked, he or she has no disease, he or she will not have a rebound effect, so will not come to smoke, well, because most of the smokers, even after quitting, they tend to come. In the document I'm talking about, there were also recommendations because actually the question was show the situation, but also tell us how to get out of there. Well, so the recommendation, the first recommendation was due to the primordial prevention. As you know, the primordial prevention, the basic prevention is always, as I already mentioned, education. So I think that, we in Poland right now have 3 publicly run and available for everyone. 38 million the population. We have 3 clinics, anti-smoking clinics, where you can go see, consult a specialist, or get advice how to quit smoking. So I dare to suggest that we should have one in every county. We have 300 counties, so I think that we have to 100-fold increase this asset that we have. Well, maybe let's start with 50-fold increase, then we'll reach the 100-fold. Well, and the clinics should be available for everyone without a referral. So to encourage people, not to discourage people, first you need to go to the doctor, you need to talk to him. If he decides, gives you a referral, you go to the clinic. No, you can, I'm a smoker, anytime I can get into the clinic and I'll get as much help as they can. Secondly, they should be responsible. These clinics should coordinate all the activities, anti-tobacco, anti-cigarette activities in the region, because the consistency of the message is paramount, and you know, even leading to 3 projects slightly different, all of them anti-cigarette, all of them are anti-smoking. But slightly different, the message, while non-consistent, is not that well accepted by the society. Well, the second advice is already not from the primordial prevention, but from the primary prevention. And this is reducing the availability. And the availability can be reduced especially by licensing the places where the cigarettes can be sold. Especially, you know, I look at every single gas station, not only in Poland. You can buy all the possible cigarettes, and even, well, if you're a quitter, you returning from a journey, you're getting some fuel, then, okay, you're already buying the fuel. Oh, can I have a pack of whatever it is? 2? So really, no selling of cigarettes in such places. This is absolutely the primary prevention. Primary, which is not education anymore, but primary, keep the person away from the risk factor as long as possible, as much as possible. So, and the second part of the primary prevention is the excise tax that we already discussed. Okay, well, put higher excise taxes, may the cigarettes really expensive. Well, we can as already has been discussed in the previous panel, we can of course go to the 30s in the United States and fighting with the alcohol, but well, I think that we have some special services in Poland that could take care of the illegal trade of cigarettes, and we, dealing with human health and with the public health, shouldn't use this as a bad excuse for not doing nothing. So we cannot raise the taxes, because the too high prices will cause illicit trade. Well, the third part is launch, well, at least the one clinic which I already told, but at the secondary prevention, they will not only be the educator and the coordinator of education, but they should be also the distributor of harm reduction techniques. At this point, they should have full access and be able to make a decision for this patient, for this very patient, in our opinion, says the clinic, the best way to support him is to reduce his harm. So, and from all the harm reduction techniques, this one, knowing the patient, will be the best, the most suitable for him or for her. And this is the second tool that such clinics should obtain and should have. Well, finally, revised legislation, but this is also the tertiary prevention when we have already failed at all the levels, and we have people who are smoking, who are sick, who are getting more sicker and sicker. Well, simply we need to introduce all the harm reduction to be legal and supported by the country. Because some of them, even if they are legal, they are distributed, but they tend to be too expensive for some people to afford them. So, okay, well, we say, buy this harm reduction technique, but it costs like 50 packs of cigarettes. So even if I want to, well, maybe I spend 50 packs of cigarettes for 3 months. But in this case, I need to buy the new technology from day to day. So this, for those who are really dependent on smoking, should be supported by their healthcare insurance, by the country, well, no matter what, but depending the system in different countries. Well, I have very often discussions with my colleagues, pulmonary medicine specialists or allergy specialists, because from my first vocation I run a department of allergy and pulmonary medicine of National Institute of Medicine in Warsaw. So I have a discussion, how can you say that you give something healthy? This is not healthy. No, I never said I give something healthy. Harm reduction is reducing harm, which doesn't mean that things that we give to the patients are not harmful. Yes, they are harmful, but they are less harmful, so they have only be given there where we know that the harm really exists, and the only purpose to give them should be to lower the harm that is being made so far. To be sure that we really know what we're talking about, I suggest, especially every country, but I suggest for the Polish Academy of Sciences to have a group of researchers who review everything which is available in the world in this subject. And if they say that this is not evidence-based medicine yet, okay, let's give some public money, whatever it takes. Let's do some research. And after this research, let's finally state, is this harm reduction or is this not? But do not deny something that you haven't checked. This is a very good regulation, and I think that the Polish government denies the harm reduction possibility on something, on the substances or the technologies they've never checked. So they say simply no, because no. And the final, I know I'm 6 minutes behind. I'm so sorry. Well, the turning point. The turning point. We looked at the case of New Zealand. Now it's a case of Sweden, who was proclaimed nearly smoke-free country this year, because as we remember in April it was 5.6% of smoking population. At 5%, so below 5%, is the border, the borderline set by WHO for confirming. But well, maybe they still at 5.6. But when we look at the cancer rate, well, the cancer rate in Sweden is the lowest in Europe. Not only in Europe, but I was looking at this from the European perspective. So it's the lowest in Europe. The COPD rate is the lowest in Europe. So it works. No matter if it's 5.6% or it's already 5%, it works. Well, the Swedes, they still dependent on nicotine, because they have the nicotine pouches, they have the heated tobacco, they have the e-cigs. Well, they still do have nicotine in their market, but they live healthier. They do not have COPD, they do not have cancers. So the success is there. When I compare Poland to Sweden, 12 years ago, Poland and Sweden were at a very close level in the percentage of people smoking. But then the 12 years passed, and the percentage of use has doubled in Poland in the past decade, and the difference between adults remained the same. So we moved nowhere good, and Sweden did. So I'd like to think that it was a nice song, follow her footsteps. Yeah, well, let's follow their footsteps. They already shown the way, as New Zealand. And when I look at the coming COP10, I think that WHO lost several battles in this field. in my opinion, lost not only several battles, but is losing the war. Because when you look at the reports of WHO in 2015, they were saying, well, we have 1.1 billion smokers in the world. This year, and well, the 31st July 2023, the same page, the same WHO, the same key facts, and they say we have 1.3 billion smokers. So the difference is visible. Of course, some of this comes from the increase of the population in the world. Yeah, I do understand. But look at the right-hand side graph. When you see that the falls you have only in the countries that are in the regions, it's not country subdivided, in the regions who are really active in fighting. And this is not that they're going the pragmatic regulation only. They're all pragmatics. They know what they can do and they know what they cannot. But if they decide to do something, they make a roadmap like the New Zealand did, and they follow the roadmap for at least 15 years, because it takes 10 or 15 years to get there. And WHO says, no, it's forbidden. Endgame is the only way to go. So, sorry, well, they're losing the war and they're not reaching the end game. And I'd say around 250 million at any time. Well, let's say the percentage of smokers, 1.3 billion. So let's say 10% of them, or up to 20% of them, are trying to quit at any chosen day. And I would expect that COP10 will address their problems, will address the techniques that can support them, will address the way to support them, will address the tax attitude to support them. Well, but from what we hear before the COP, it's rather they'll focus on banning and closing these ways, not to support. So I'm afraid this is a kind of way of punishing those who want to quit. It's much better that you guys keep smoking cigarettes, keep pushing some money into budget, keep pushing some money into other pockets. Well, that's the way to go. Yeah. Well, summarizing. NCD spending exceeds the tax benefit on alcohol and cigarettes. So we started spending more than earning. The only difference is that we earn now and we cut the spendings in 10 or 15 years. And we need the money now because the budget needs money now, not in 10 years. Well, the financial demand on the health care rose during the pandemics, we know, and it's very important because we need to face it right now, and we'll keep facing it for the coming decade. Inflation rose to its maximum, which also increased the expenditure in the healthcare sector. A total cost attributable to smoking cigarettes, as I told you, worldwide is around 2% of GDP, exactly 1.85% of GDP. And Poland could save up to 90 billion, according to analysis that I presented you only parts of. But according to this analysis, Poland could save up to 80 billion, which is euro 20 billion yearly, but in 10 years after introducing this policy that I gave in 5 short points. Well, let's hope that someone takes time to read the analysis, and maybe someone at least introduce a part of it. Well, wisdom goes behind money, and it should go, well, it should precede, so it should go before, and the wisdom says that prevention and harm reduction are the most effective way of cutting costs and investing to the future. Lifestyle changes, reduction of behavioral reduction, because, well, I really do not trust that we can cut them radically. So NCD are responsible for over 90% of premature deaths in developed countries, and they are also responsible for over 60%, so almost 2/3 money that we're spending on the curative medicine. To stop the smoking pandemic, its financial and public health effect, we need to raise funding to primordial prevention. Let me remind once again, primordial prevention, which is lifelong education, and introduce the less harm, less tax regulation. So high taxation for the most harmful substances, low taxation for the least harmful substances. Well, thank you very much, and I'm sorry for this 8 minutes. Thank you.